This is the summary of antitussives, expectorants, and mucolytics for your board review. There are only 6 major drugs to study in this. This is an easy lecture. I divide this into 3 classes. Antitussives, mainly used for dry cough to reduce or suppress cough reflex. Keep in mind, dry cough will not produce mucus, but this is because of some of the drugs adverse effect or after post-infection or some other reasons, right? So here we need to suppress the nervous system. It's actually, this is impulse stimulated by the nerve endings in the respiratory tract will cause this cough. That is the reason these drugs targeting the neurons. Okay, we will divide all those, but the wet cough usually mainly associated with your goblet cell secretions. That goblet cell secretion is actually mucus secreting cells, right? So mucus is related to wet cough in patients, but of course we need specific mucolytic drugs in patients with a chronic respiratory syndromes. In that case, we can use certain drugs, including cystic fibrosis. We can use certain drugs. We're going to talk about that. Okay, let's distinguish this one. Let's focus on antitussives. Okay, antitussives, dry cough due to different situations, but when do you use and how to distinguish these 3 drugs? Very easy to understand. Okay, when a patient get like a moderate or mild cough due to the airway irritation or post-viral infection, or whenever you don't need any CNS depression, if you need to avoid, you go for benzonatate. Keep in mind, mainly the big picture is you need to figure it out what is the causative or what is the reason the patient's cough is. That is a significant point before you prescribe the drug. Anyway, let's talk about that. Benzonatate is a peripherally acting drug, but the next 2 drugs, codeine and dextromethorphan, can pass blood-brain barrier. That is actually a centrally acting drug. Okay, so another point, how I remember is A, B, C, D, E, F. That's how these drug division, but let's talk about that first section. So benzonatate is a drug which affecting peripherally. That means, how I remember is, this is actually controlling the vagus nerve signals, suppressing vagus nerve signals, sensory signals, so that it will not reach into the brain, so that we can regulate or suppress cough. So let's talk about that. Benzonatate, how do they suppress vagus nerve signals? By blocking sodium channels. So keep in mind, this drug will not pass blood-brain barrier, but instead affecting the vagus nerve endings near your lungs, bronchioles, and also into the pleura. So keep in mind, your vagus nerve is well innervated into the lungs, right, for the regulation. But that nerve signal action potential is blocked by the sodium channel blockade. Okay, this is oral drug, is like a jello, usually not for kids. The reason FDA is not indicated for this patients under 6 years old. One of the reason is this can, if the patient chew this, the liquid can ooze into your tongue and your buccal area. This can numb your mouth. If you chew, you're going to bite on your tongue or your lips, so that is going to be severe condition. So that is the another reason you should never chew this tablet. Okay, so keep in mind benzonatate, and it can cause sedation and drowsiness. Therefore, you should never add alcohol with this drug. Okay, so keep in mind, benzonatate is a peripherally acting drug. It affects the vagus nerve signals. How do they block mechanism? How do they block the sodium channel blocking? So I have a mnemonic if you like to remember. My auntie had a Benz car. She goes to Vegas to drink soda to get drunk. So vagus nerve signals will be blocked. How do they blocked? By blocking sodium channel. Okay, and she had a constipated cat named Cody. She always cried meow meow meow. So mu opioid receptor agonist is called codeine. So let's talk about codeine. Codeine is super important. Codeine, of course, all these drugs are usually, but compared to cardiorenal, like all those other drugs, it's less important, but still board like to ask. Okay, so this drug is like a schedule 5 that is low dose, is the one using for dry cough. Keep in mind, when do you use? Okay, so this is only for severe cough, chronic cough, and also associated with a keep in mind, if the patient, this cough is affecting their sleep, this will be effective. Okay, keep in mind. And dextromethorphan, okay, I forgot to distinguish all those 3 indications. Dextromethorphan usually given to patients after post-operative cough. Commonly used, less, there is, it's a non-narcotic drug, therefore dextro is the preferred drug compared to the other 2. Anyway, codeine, let's talk about that. This is a centrally acting drug. It can pass blood-brain barrier. How do they work? It's going to agonize mu-opioid. So codeine's metabolite, codeine 6-gluconate, and also a part of metabolite form morphine, all those can block the CAMP and calcium signaling and increase potassium outburst, and this can result in suppression of your cough signals in the respiratory center, medulla and pons, mainly in medulla. Keep in mind, your medulla has a lot of mu-opioids. Therefore, when you give codeine can easily pass through the brain, and it can activate the mu-opioid receptors in the respiratory centers, which in turn suppress the calcium signals and suppress the action potential, and therefore the patient's dry cough can be controlled or regulated. Okay, what are the other things to remember? The same mechanism associated with a adverse effect. More than 50% of patients can get constipation. Okay, keep in mind, codeine, low doses for dry cough or antitussive, even though low dose can cause adverse effect, constipation. Why? Same mechanism. Mu-opioid receptors are rich in your myelinic plexus and also mucosal layer of your digestive system, specifically in the colon. Therefore, this codeine clamp the colon. That's another mnemonic, if you like. Then codeine can increase fluid absorption, reabsorption, increase absorption, and also reduce the smooth muscle contraction or the peristalsis. This can result in constipation. Okay, the same mechanism, mu-opioid receptor agonism. Okay, another point to remember: codeine can metabolized by CYP3 2D6 into apart into morphine. That is the reason morphine can increase the dopamine in your brain centers, and it can cause addiction and all. That is the reason in some patients, if the CYP2D6 level is different in the patients, the level of morphine formation will be also different. So associated with that, keep in mind. Okay, then its adverse effect we already discussed. Of course, a serious adverse effect is CNS depression or respiratory depression will be another. Codeine, because it is that unique drug, I wanted to study 2 adverse effects, but most commonly used patients get in dry cough is constipation. The next drug is dextromethorphan. So what is the major things to remember? This is a non-narcotic drug. Of course, like codeine, unlike codeine is a narcotic drug. Dextromethorphan is a non-narcotic agent. But this dextromethorphan is actually a centrally acting drug. but it can pass to the blood-brain barrier and change into a highly active component called same enzyme CYP2D6 chop this dextromethorphan into dextromethorphan. That is highly effective, which can pass the blood-brain barrier very easily. Once it gets into the liver, like a CYP enzymes chop and modified into dextromethorphan, this dextromethorphan can activate the sigma opioid receptors. So let's talk about that. Remember, codeine mechanism of action, agonizing mu opioid receptor, right, in the respiratory center. But dextromethorphan can agonize sigma opioid receptors, and also they can block NMDA receptors or glutamate receptors. Why is it super important? This can affect other neurotransmitters because it is a major neurotransmitter. Glutamate is involved. So let's talk about that. Dextromethorphan in the dose for dry cough mechanism, two mechanism, activating sigma opioid and also suppressing NMDA receptor. That means NMDA mediated cation channel will be blocked. Therefore, less cations will be passing through. Therefore, in the medulla, your respiratory centers, cough signals will not be passing. Therefore, the patient will not cough, right? So keep in mind, that's the mechanism for dextromethorphan. Other point, this drug dextromethorphan can secondary effect. It can cause the serotonin and norepinephrine reuptake. That means block the reuptake transporters. Therefore, the patients can have so many serotonin molecules and a norepinephrine molecule in there throughout the brain's synapse. This can result in a drunk feeling or euphoria. So that is the term related to robotripping. That means, remember, dextromethorphan tablet, bilayered tablet with the guaifenesin, or dextromethorphan combined with the guaifenesin can be marketed in the over-the-counter medication as a cough syrup. That is called robitussin. So that drug patients, some teenagers or adults, if they are using to get that drunk feeling, that is called robotripping. So keep in mind why they feel that euphoric or a drunk feeling. This is related to those three neurotransmitters. Mainly, this dextromethorphan and dextromethorphan can increase the availability of serotonin and norepinephrine in the synapse, in addition to the normal function. Okay, so why is it causing? Because of its mechanism, unique mechanism. That one of the mechanism is by stimulating sigma opioid receptor, but the secondary mechanism is blocking NMDA or the glutamate receptor. Okay, so this is how I remember my auntie's husband Dextro is a drug addict, or MDMA or meth addict, drunk feeling, euphoric feeling. It says he's a sigma male. I don't know what that is, but just remember whichever way. And anyway, dextromethorphan is different. So one more point I want you to add, because this drug you may see in different section to treat pseudo-bulbar effect. What does that mean? It's a corticobulbar pathway will be blocked in some patients when they get like a stroke or ALS or a multiple sclerosis, and they end up in uncontrolled or involuntary laughing and crying. They cannot control. They will keep crying or keep laughing. How can you block? How can you stop that? By blocking by blocking the glutamate receptor, NMDA receptor. So that is why that mechanism is also super important. Dextromethorphan's secondary mechanism is specifically used for pseudo-bulbar effect, in addition to this dry cough mechanism of action. Okay, so dry cough, you can remember both the mechanism, sigma opioid receptor agonism and NMDA receptor suppression or antagonism. Okay. So in that condition, pseudobulbar effect, when the patient cry or laugh uncontrollably, if you give dextromethorphan, the problem here is as soon as you give within an hour or so, completely, because this drug can be metabolized in the liver by CYP2D6 into dextromethorphan. Very quick, dextromethorphan and all the other metabolites eliminated filtered through the urine, glomerular filtration, very fast. But you need to sustain, the patient has to continuously regulating, right? Therefore, dextromethorphan can be given with quinidine, another drug, so that quinidine can block CYP2D6. Thus, you can keep the dextromethorphan's effect continuously, constantly in patient's brain. Of course, the parent drug dextromethorphan also can control that or agonize the sigma receptors, opioid receptors in the medulla, and also it can block the NMDA receptors or glutamate receptors in the brain. So keep in mind, so that is the reason patients can get that regulation or the if you're actually limbic system calming down and that overexpressions, right? Okay, keep in mind this dextromethorphan's mechanism and adverse effect, drunk feeling, all those points. Okay, the next one, mucokinetic drugs will be done soon. Guaifenesin is the drug expectorant for sputum like dilution or mucus out, thick phlegm out by Guaifenesin. So what is the significance? Most of the smart physicians will say like, okay, this mucolytic drugs will not work for common cold. What is the reason? Easy to remember. During cold, most of the time that may be due to viral infection, right? Viral cold is generally starting with like a very thin mucus and like a lot of mucus secretion. Therefore, this mechanism here, expectorant, we expect guaifenesin to dilute mucus. So thick mucus will be diluted by guaifenesin. The guaifenesin adding or refining the mucus. How do they add? Add water, hydration. Increase the secondary effect is by decreasing surface tension. So how do they do? Guaifenesin adding all this water into the goblet cells. So goblet cells start secreting very dilute mucus. Therefore, in patients with, if there is like a after infection, right, specifically like a chronic infection and a dry thick sputum can be in patients. In that case, if the patient take like a Mucinex or Robitussin or this specific drug, you can dilute the mucus. That is the reason in common cold, because of the viral infection, usually this is not that effective. So keep in mind that point, okay? Cough and wet mucus, so that drug have different distinguishing indications. Guaifenesin's indication is to add water and dilute the mucus secretions. Very good. The next one is, so expect phlegm to go out by guaifenesin. Mucolytics. Okay, let's talk about mucolytics. Mucolytic drugs are mainly used for chronic lung disease with a lot of thick sputum or mucus in the respiratory tract. Easy to understand. There are three divisions. All the three drugs you study in a three different one. If the patient has thick mucus layer, you need to dilute, not by adding water. This is nothing to do with the water. Remember, we can give a drug called NAC. It is called N-Acetyl cysteine. N-Acetyl cysteine is rich in SH bond, sulfur hydryl. So this sulfur hydryl group will help to break down. It act like a sulfhydryl group, act like a scissors, right? This is going to chop down disulfide bonds in the mucus. So keep in mind, mucus has a lot of thick, to make it thick, it has that disulfide bond. So here, this bond, disulfide bond can be chopped down like a scissors. NAC can be chopping down. How? NAC has a additional free sulfhydryl group is there. That is why when the patient use nebulized form, that's how I remember NAC for nose, nebulized form. NAC commonly used for chronic lung disease with a thick mucus to break the disulfide group. And it has a rotten smell. Reason NAC can produce a lot of release hydrogen sulfide. This can cause that smell, okay? But still it is very effective to break down the thick mucus. Keep in mind, I want you to study two things for NAC. One for mucokinetic function as a mucolytic. That is, you know that, by providing HSH, sulfhydryl group as a scissors, acting in the lungs. Very good. But this drug is effective in the liver. That is an entirely different mechanism. If a patient do acetaminophen overdose, the patient will run out of glutathione. So how do you remember? NAC, N-Acetyl cysteine, provide cysteine to your liver cells, hepatocytes, so that they can provide or produce a lot of glutathione to chop down all the acetaminophen producing NAPI. We will talk about all those in details later in another lecture. But keep in mind, N-Acetyl cysteine has two mechanisms. One mechanism in the mucokinetic in the respiratory system, lungs, that will be as a nebulizer or different forms we can use. Commonly in nebulized form, you can use it when the patient respire. As soon as it gets into directly chopping, it's like a scissors, chopping all the disulfide group bonds of the mucus so that it will be eliminated and diluted, right? So that's not adding water here. Mechanism is entirely different. So cystic fibrosis patient also can be used in this as a nebulized form. NAC, secondary function, providing cysteine to the liver cells. That is why acetaminophen overdose. Okay, those are the most commonly asked board questions. So that's why I wanted to distinguish that as two different mechanisms. In the lung section, that will be by providing disulfide bond. Okay, so how I remember is nebulized NAC for nose, or NAC clears nasty mucus, whichever way. Okay, by breaking disulfide bonds. Okay, the next one, if a patient has airway pus, okay, if it is a cystic fibrosis or whichever condition, if the patient chronic lung disease conditions, COPD and all those, bronchitis, all those, airway pus, if the patient has, you can use a drug called Dornase-alfa, very effective. So let's talk about that. Why do they get a DNA in the lungs, right? Along with the pus, along with the mucus. Reason, that's why DNase. It's going to chop the DNA of the dead white blood cells. Dornase-alfa. That's why the drug's name Dornase-alfa. Easy to remember. In some patients, the airway mucus, because too much mucus secretion, your white blood corpuscles will get out from the blood vessels and into the lungs and bronchioles, all those areas. These white blood corpuscles trying to recruit there, right? It's like a military recruitment. But the problem here is, because the mucus is so dry and thick, they will end up in dying there. They cannot get into the blood vessels later. They will be stuck there and die. They produce a lot of DNA, dead DNA and filamentous actin polymers, all those form pus in some patients. So whenever in this condition, we can use a drug called Dornase-alfa. Dornase-alfa can be effective in all these chronic lung disease or cystic fibrosis patients. It will be breaking down that DNA. I have that picture. So the DNA of the dead cells and eliminating so that the mucus will be thin. Okay, so that is an entirely different. So three different mechanisms here we explained, right? Dornase-alfa is effective to eliminate DNA. That's how I remember. And thus it can be useful. Okay, pus outdoor. Pus outdoor by Dornase. How do they change the pus? Pus in the presence of white blood cells. That's how easy, by the breaking DNA. And the last drugs in the class, they're called caftors. Okay, keep in mind CFTR specific gene, specific proteins. These are because of the gene mutation in cystic fibrosis, especially. Keep in mind, about 90% of patients with a cystic fibrosis has the specific gene mutation called F508 deletion. In this patient, their chloride channels are not functional. That's a major point to remember. So what is that? That is because of the cystic fibrosis transmembrane conductance regulator protein, that is called CFTR protein, that is associated with a chloride channel. This is all you need to remember. In the lungs of the patients, or in other organs we will talk about, the specific chloride channel is not supplying or conducting in and out chlorides. Reason, there is a mutation, F508 deletion. Patients like liver, pancreas, all these organs will be ineffective in this, mucus accumulation will be happening. But keep in mind, the specific deletion can cause non-functional cystic fibrosis condition. But the drug Ivacaftor, specifically that drug, will help to open the chloride channel. So I have this chloride channel in the membrane of the throughout the respiratory system. It's not opening, so that chloride is not transmitting, so that water is not working well. Chloride is not providing the not providing chloride ions, and thick mucus end up in having really non-functional lungs or nervous system, the pulmonary system. So therefore we are going to induce, that's how I remember, IVA opens the chloride gate. It's like a gating. They're going to open the gate. Even we can give as monotherapy. Only about 5% of cystic fibrosis patients have uniquely that opening and closing of the gate. Chloride channel gating will not be functional. So as soon as you give this drug can open that channel, so that the patient will be very effectively use this drug. But there are some patients, they will not have functional chloride channel on the membrane. Nope. Or not even producing. In that type, the specific, the membrane translocation or function, nothing happening. That is, the real functional unit is not producing or translocating into the membrane. So that is the time, if somebody asks you what is the difference of these drugs. So Elexacaftor, Tezacaftor, all those drugs are called correctors. What is the difference between potentiator and corrector? Corrector will help to produce chloride channel through the specific genes, activate and produce a specific chloride channel. But potentiator help to, when they translocate, potentiator helps to open the chloride channel. That is the reason Ivacaftor with these two drugs, the three drugs together, called triple combination therapy. The triple combination therapy for the chloride channel, both the functions for functional production and the opening of the chloride channel. This is very effective for 90% of patients with this specific mutation. Okay, keep in mind with the cystic fibrosis. That is the major difference. I think I already covered. But let's review what are the major things to remember. Remember, dextromethorphan and codeine, those have different indications also there. But for the dry cough, this is the we are targeting the neurons, right? That is the reason. There is nothing to do with the goblet cells, dry cough. Only you need to control cough reflex. But wet cough is associated with the goblet cells, right? They are the ones supposed to produce over secretion of mucus or thick mucus, all those accumulation of mucus. So what we do is expectorant to remove phlegm out or sputum out, adding a lot of water and reducing surface tension and producing the Guaifenesin drug is functioning. But mucolytic, you chop down the mucus. How do you do? by specifically mucus chopping down is done by thick mucus is breaking down by NAC, N-Acetyl cysteine. How do they do? By providing SH group, sulfur hydride group. It acts as a scissors to break disulfide bond in the thick mucus. But if a patient has an additional, like a too much DNA stuck in the mucus, you have to remember, you must know as a physician how this DNA comes in the mucus. How? Because of the thick mucus or dust cells and all these white blood corpuscles, when they get in there, they cannot get back to blood supply or into your tissue, and end up stuck there in the mucus and dies. In that time, you can use Dornase-alfa. They're going to chop down all the DNAs and remove that the pus also, that all these mucus also diluted. This is going to eliminate very fast once you chop down all those mucus and the content. Okay, the next section I talk about, out of 90% of the cystic fibrosis patients with the deletion, if the patient has that specific gene mutation, you have to remember, supposed to remember 5F508 deletion and a CFTR specific protein damage, right? That condition, to open chloride channel, you can give potentiator, even you can give it as monotherapy, Ivacaftor. But if you don't have the functional chloride channel, you have to give the the combination triple therapy. You can give that three drugs as a combination to these are specific to cystic fibrosis drug. If you have to avoid cystic fibrosis for the chronic lung disease mucolytics, you can use the other drugs, right? Dornase-alfa targeting the DNA, N-Acetyl cysteine for your disulfide bond breakage. Remember, N-Acetyl cysteine, I want you to remember, providing cysteine to your liver during acetaminophen overdose. Why? Cysteine can stimulate a lot of glutathione production, availability to eliminate the poisonous toxin produced by acetaminophen. We will talk about that in another lecture, but this is it. I hope this helps. The next lecture of pneumonia I'll release in another day. You can refer, and also keep in mind codeine and codeine, benzonatate and dextromethorphan. I put other videos are available in this channel with the detailed pictures if you like to look at all those. This is a review after listening to the lecture. You can use this. Okay, thank you. Hope this helps.